Good afternoon. Welcome to CDI Innovations Digital Edition 2020. We're in the aortic session. My name is Ashish Pershad. I'm at Banner University Medical Center, Phoenix. I'd like to talk about a case related to a difficult balloon expandable TAVR case and how I managed it. These are my disclosures, none relevant to this presentation. So diving right into the case, this is a 70-year-old female patient who had oxygen-dependent pulmonary disease, chronic kidney disease, moderate pulmonary hypertension, diabetes, hypertension, and high cholesterol. Her STS risk for an isolated aortic valve replacement was 5.4%. She was on optimal medical therapy for heart failure with an ACE inhibitor, diuretics, beta blockers, and was on an aspirin and a statin. Her electrocardiogram was unremarkable, as can be seen on the lower right panel. Invasive hemodynamic data confirmed the presence of severe aortic valve stenosis, bringing gradient to 40 millimeters across this aortic valve. CT scan was revealing for multiple problems that we might encounter during this case to make it challenging. The first challenge was the annular diameter. The diameter of the annulus was 333 millimeters squared. This is a small annulus by any measurement, which would automatically raise a red flag in terms of potential need for root enlargement and or some kind of a situation where it sets her up for a patient prosthesis mismatch down the road, or at the very least, elevated gradients at the conclusion of the procedure. Several other challenges. Annulus to left main distance was low at 6.6 millimeters, and her right coronary though was non-dominant and felt to be also low. But as you can well see on the CT scan in the lower right panel, how low the left coronaries are and how effaced the sinotubular junctions are. All of these things were concerns and makes this a extremely challenging balloon expandable valve case. Like I said earlier, the sinuses were effaced. The STJ was also narrow, and the diameter of the STJ was 24 and 25 and 23 millimeters respectively. The aorta at 40 millimeters was at 30 millimeters. There wasn't a whole lot of calcium in the aortic arch, as well as in the aortic valve per se. So the pertinent findings in the CT was a perimeter of 66, a annulus area of 333, an STJ height of 16.8 millimeters, a STJ diameter of 23 by 25 millimeters, low left main height, low right coronary height, and sinuses that were effaced at 23, 27, and 24 millimeters respectively. The only good thing going for us in this case was the access was excellent, and there wasn't a whole lot of calcium anywhere along the way. Our strategy was to do a basilica to mitigate left coronary risk of obstruction given her age, and hence we chose to plan for a left coronary basilica. The right coronary being non-dominant was thought to be something that we didn't need to perform a basilica for the RCA. So the setup, for those that are unfamiliar, is a dry seal sheath in one of the sides. In this case, it didn't matter. Both sides were suitable for TAVR. We put that on the right side and a couple of 6 French sheets and an artery and vein on the left side. We initially were using a pachyderm catheter, but because of the size of the aortic root, it just was too large. And so we chose an AL2 here, and on imaging, we're able to line the AL2 catheter underneath the left coronary cusp at the base of the leaflet, and we're able to traverse, as you can see, within a starter wire on a piggyback catheter fairly easily into the left ventricle in real time with a snare in the left ventricle uh, just in the outflow tract, being able to grab this starter wire and pull the starter wire into the snare on the aortic side. Once we accomplish this, we then back the starter wire, the piggyback catheter back, and expose the starter at roughly half its catheter length, namely at about 150 centimeters, and at the hub of the sheath in the groin, denude it and create the flying V. We then lock the piggyback and then advance the starter through the tui with the snared wire on the contralateral side, and are able to bring the flying V to the zone of interest, which is under the left coronary cusp. Once we've done that, we perform the laceration itself at a bogey set at 70 cut without any coagulation set on the bogey. We then are gently pulling both catheters with tension, but and at the same time advancing dextrose through the side ports of the catheter to make sure that the electrical isolation is maintained and the energy is transmitted to the tip of the stato at the desired location. As you can see in the right panel, we've successfully performed the laceration, and the patient has a significant amount of AI, which you can hopefully see on the root angiogram as well as on the echocardiographic image on the right panel. Oftentimes, hemodynamic compromise is not immediate and allows for enough time to perform the TAVR procedure after this is done. So this is the root angiogram. Traditional sapien procedure is then performed. A 20 millimeter valve is implanted, like shown in the left panel, with pacing guidance. As you can see on the imaging on the right side, the valve is actually very well seated. There was minimal gradient, and flow in the coronaries was preserved with successful performance of the basilica. So in conclusion, this is a classic example of what I call the trifecta of a small annulus, sinuses that are effaced, and low coronary heights. This is a harbinger of a tough TAVR procedure, and unless you're antennae out and have a good game plan, can lead to catastrophic complications. Seriously, surgical aortic valve replacement must be entertained because the surgeons can do root enlargement plus resectomy of leaflets in patients who have surgical eligibility. In high-risk patients, of course, coronary protection and basilica are potential options. I'm in favor of performing the basilica rather than a snorkel in the coronaries, just because of reaccessing the coronary. A future coronary intervention might be difficult, as well as the risk of stent deformation and sinus washout, all of which have unproven benefits of the basilica in favor of performing it versus implanting a stent in the left vein as a coronary protective maneuver. Thanks for your attention, and enjoy the rest of the conference.